So what Laurie has just kind of gone through is the eligibility and enrollment, and that all takes place and is done by Dee. She identifies the patients that are eligible, and all of that's done prior to discharge. As you see here, I'm going to go through the other pieces of the implementation of the model of care. That includes the 2-day after discharge follow-up phone call, the functional assessment, there's a caregiver assessment, and then there's also what we call an advanced practice assessment as well. So just give me 1 second to pull up this here. Yes, okay. So what you're going to find is that I'll just kind of orient you to the screen here. You've got today's date and time. You've got the patient's age, and the Compass ID. So this does not correlate with your medical record number. So after the patient goes home, Dee makes a 2-day follow-up phone call, which she inputs data here where I'm clicking. And in order to view this a little bit more quickly, it's easier for me to pull it up in what we call this provider report. But she's already made a phone call, and this provider report will tell you exactly what she asked. So she's asking for things about symptoms after discharge. She's performing a medication reconciliation and seeing if there are any issues that may need to be addressed, and that can include things as simple as the prescription went to the wrong pharmacy, or cost of medication, any sort of barriers that would prevent the patient from getting the discharge medications that were intended. They're asking for any new or worsening stroke-specific signs. For those patients who it is applicable, they're asking about making sure the INR plan and follow-up had been taken care of, and that the patient was, further educated about Coumadin, especially if it's a patient that's new. The other thing they're asking about are any services that stroke patients may need, and those are patients can be both home health or outpatient services, and specifically what was ordered for that particular patient. So you'll see there that this was, hold on, I've got him, there you go. You'll see there that those were the things that were asked on the 2-day phone call. So at this point, this is where part of the provider aspect is important in the Compass model of care. Some of the main issues are really related to prescriptions, as well as therapy referrals. And oftentimes the nurses, Dee will identify these, and she either, and I'm not sure her current practice of care, but some sites of Compass go back to the discharging physician to try to help to resolve any issues that may be identified. Some places, such as Wake Forest, when we know that we're going to be seeing the patient within a timely manner, we do cover these sorts of issues that may arise. And it's sometimes just refilling prescriptions, sending them to different pharmacies, perhaps changing one if the cost was a big barrier, and then reordering. Say a person was sent home with outpatient therapy, but then they realized that transportation would be a problem once they got home, so, or perhaps copays and stuff, so we would just then cancel that and reorder some home health therapy and things like that. So as a provider role in the Compass model of care, you may be seeing those kinds of things for your particular patient. Now, the second thing that you'll see is at the bottom, these are called the disposition forms. And this is asking about, these are simple forms that Dee is filling out, and it just is saying, you know, was the call completed and what date was it completed? These are our ways to monitor the quality metrics and the performance status of each site to see how realistic was it and how well did our sites achieve, you know, our goals that we had set for this model of care. So the next thing that you'll see is what we call the post-stroke functional assessment. This is the stroke caregiver assessment. So Dee, who's functioning as your post-acute coordinator, will be helping out with you guys in clinic. And what happens is usually the patient is roomed, and then Dee will go in with the patient and perform this post-stroke functional assessment. I'm going to click on it, and you'll see that this has a status bar up here, but there is, for each patient, there's a series of questions related, and they're pretty standardized questions that go through comprehensively typical needs of stroke patients. And they're not always going to be pertinent to each patient because some will be talking about swallowing and aphasia, whereas others will be focused more on physical aspects. But what you'll see is that there is a logic that was built to these questions. So for instance, if you have a patient who is a TIA follow-up that doesn't have many physical deficits or social needs, they perhaps will only answer 12 questions and not have the remaining amount of questions because those they have not triggered any red flags up front. But you will find that those patients that are, you know, sometimes we refer to them as heavy hitters or train wrecks or whatever you want to say, but they sometimes can be where they would fall into all 52 questions. So this post-stroke functional assessment can take anywhere from 7 minutes up to about 15 minutes to do. So we want you to be cognizant of this in your timing as you're thinking about your clinic and scheduling of clinic patients. Some of our sites certainly ask the patients to come in 15 minutes earlier to account for the time with the nurses. Others have created a longer visit hour for the patient, so it does just depend on your site and what it is. I think that you'll find that in this functional assessment, Dee is going to be asking many of the questions that you usually ask your patients. So you may find that a lot of this has already been asked. And after the functional assessment is completed, Dee will then come out and report to you the red flags that we're seeing. So you may find that you're able to then streamline exactly what you need to talk about to make your time more efficient when you're in with the patient, to focus on that patient's actual needs. So I'm going to go through a few of these, and then we'll go back out and I'll show the summary of what is being assessed for. So the first few basic questions, and these would come for every patient. Since you are hospitalized, have you had enough money to buy medications? And do you know your risk factors that may lead to stroke, and what are these risk factors? So this is about patients being able to self-manage their comorbidities. How would you rate your health from being scale of 1 to 5, from poor to excellent? So this is about patients being involved in assessing their overall health and stuff like that. Then you get the physical questions. Can you go up and down 10 stairs without help? How difficult is it to use your hand or your arm, which was most affected by your stroke? I'm going to do this. And then you have you a fall assessment. Have you fallen in the last 3 months? Did you get injured? You can see those questions. Have you fallen more than once? So this is a falls risk assessment. Then you do have cognitive screenings in here. The nurse is asking the patient to complete the sequence, the 1A, 2B, 3C, what would come next. These are screening tools to see if the patient's getting them correct, or more importantly, if they're not getting them correctly, then perhaps a new cognitive testing should be performed that's more in depth, and thinking about crucial factors such as medication management by the patient, or driving, and those kinds of things should be thought about. But from the cognitive standpoint, you've got the sequencing. You also have a polypharmacy question. How many medications do you take per day? We're going to put 5. Do you have someone to help you with ADL type activities if you ever need assistance, and who are they? And since your stroke, have you often been bothered by feeling down, depressed, or hopeless? You'll recognize this as as part of the PHQ-2 assessment. And since your stroke, have you been bothered by little interest or pleasure in doing things? So this is the PHQ-2 assessment too. Over the next 3 months, do you think your health is going to improve? And then you've got, what are your primary reasons for staying as healthy? And we'll write return to work, because that's what we would all say. So you're going to put, and then the next few questions ask about your ability to take care of yourself and move around. Can you walk at least 15 minutes without getting short of breath? And can you walk without feeling unsteady? Talking about the balance. And can you get up out of chair without using your hands? These are, the PI for this project is a physical therapist, so you can see that many of those are those basic physical therapy screenings. Can you use the phone to call your family or doctor if needed? So this is talking about safety and living at home, looking for your ability to prepare meals and do housework. This is about safety, about living independently at home. Can you bathe and shower and dress yourself without any assistance? And do you have trouble controlling your bowels or bladders? I'm going to put that no here. And then these are the next additional cognitive testing. So can you tell me the week, month, and year correctly? And then I wanted to get to this. Yes, this is the delayed recall question. So it's giving 3 words and asking the patient to remember the words. And then lastly, you have, do you need help managing your medications, such as putting them in a pill box or helping them open the pill box, those kinds of things. And the last one, were you able to buy all of your medications? So financial screening. And do you ever stop your medicines if you feel better or worse? So these are for patients to know the need to continue medications like antihypertensives. And do you ever forget to take your medicine? So I'm going to put no here. And then finally, you've got that 3-word recall cognitive screen. So out of all of these, those would be the questions that the patients would be all asked. And so then you would be done for those patients who are likely TIAs without any sort of social needs or complications. But the others you'll keep going through, and it's triggered based on the previous answers if you get more questions to kind of figure out more about what's going on. This is asking about swallowing foods, chewing foods, so for dysphagia. This is looking at increased stiffness in the arm or leg, which is talking about spasticity. And talking about, can you drive yourself to and from places? And if you can't drive yourself, do you have transportation to get to appointments? Do you and then you'll see here, and this probably will be positive. Most of your patients will have this or will be establishing with you guys. But do you have one doctor that knows you or all of your medications? And that's really referring to, do you have a primary care doctor established? And what is that name? We're going to put that. And then have you seen them in the past 3 months? And we'll put yes. And have you seen them since your stroke? Because we want to emphasize the importance of primary care follow-up after your stroke. So I'm just going to finish this really quick. And so this is, so we're also looking at asking questions about, have you been hospitalized since your stroke or been seen in the emergency room? And we're going to say the person is receiving home health services and they are not receiving outpatient therapy services. And as you can see, I'm almost completed. And this person, we're going to say, is using a walker. Just so you'll see this in a second. Okay. And additionally, you'll see that all questions are going to, patients are going to be asked about, do you have a living will? And if they say no, the questions are, would you be interested in receiving any information about a living will? So this one's completed. And this is all the questions that Dee has just asked your patient. So you have not seen the patient yet. But as you can see, just by taking the time to sit down and do those questions today, don't you think that these are quite a few of the questions that you would have probably asked or wish you had asked if you had had time, just to make sure that they comprehensively can be improving. And these are all, we know, stroke-specific related. And that way, when you go back in, potentially if the patient had cognitive impairment or was screened for depressive symptoms, you can focus on that and then spend the rest of the visit really going through perhaps risk factor management like the diabetes or the blood pressure, reinforcing what you're doing for stroke prevention, those kinds of things. The last additional part is called this post-stroke advanced practice assessment. And this is for, most of these are kind of for research purposes, but also to talk about important educational features in patients recovering from stroke. And for some sites, the nurse does fill this out because this can kind of be extracted from the medical chart or asked really quickly. So it's about, are they engaging in physical activity? If so, how many minutes per day? Do you educate about the importance of physical activity? How often does the patient smoke, drink alcohol, or do recreational drugs? It's looking at blood pressure results. It's also looking at, and these are blood pressure results from the time of your visit, not the hospital stay. The hemoglobin A1C, as you know, in the stroke workup is done in the hospital. Perhaps the INR is available, so that would be updated from the last one that the patient had after the hospital stay. And save the LDL was obtained from the charting as well from the inpatient evaluation. And then it's looking at communication deficits from a stroke and filling out what we call the modified Rankin score. In the stroke world, many of the major stroke trials are based on outcomes. The outcomes are based on the modified Rankin score, so that's why this is here. And then if the patient needs a caregiver, do they have one? And I'll put does not. So as you see, and then I want to go in. So say D has done all of that before you've ever seen the patient, and that can again take anywhere from 7 to 15 minutes. D can come out and verbally report to you the concerns that she has seen, or this is a provider handoff report that you can see summarizes the answers to the patient's questions in a quick manner. And this is the follow-up phone call that we had looked at earlier. But this is that functional assessment with all those questions that are with a quick answers for you to review to see what the patient said. And you'll see that these are general categories of assessment, and it's followed by the patient-specific answers. So I'm going to scroll down and let you guys look at this in a small fast or a relatively slow rate. Just general information, medications, falls, physical mobilities, ADLs, cognition, depression, access to primary care, emergency department, and status of advanced practice directive. And as you can see, if there was a concern, it will be listed here. But if not, you can see that there were no concerns identified. Some of our sites have used this as an ability to copy and paste it from the PDF file. You can copy it, and we can paste it in Epic. But certainly you can see if you can copy and paste it in your note as a part of the HPI. But that is up to you. It is not necessary. Your ability to chart the note afterwards can be based on whatever format that you choose. Okay, so we're going to go back here. The next, I'm going to pause there. So D has gone in, she's asked all of these questions, she's come out, she's reported to you the concerns, then you're able to go do the hospital follow-up with the patient. Hopefully addressing the concerns that were brought up during the functional assessment to see if these are actual concerns or if there's more to the story and it's not really a priority for the patient. And what you'll do afterwards is, as you're developing your plan and getting ready for the patient to go, what we like to do at this point is get a patient plan of care that can go home with the patient and summarize all those questions and nice information in one easy to read format. And this is at an elementary-like grade level. So how this works is, as long as you have all these 3 things in green, and perhaps if needed, the caregiver assessment performed, you go to build the care plan. And again, this is for patient specific, so the patients are seeing this. And based on the answers to that functional assessment, this patient has shown that there may be concerns with polypharmacy, caregiver issues, perhaps some home health or outpatient services needs. And as you see, if I went in and really realized, hey, it's not, polypharmacy is not an issue here, I can click on it and it will not be displayed on the care plan. so the patient won't be, you can focus this to the highest priorities of the patient. But for this purposes, I'll leave it here so you can see what it looks like. So once you decide which things are pertinent for the patient to have on the care plan, you hit preview that care plan. And this is a draft report that you can review. We've got our generic cover letter with positive messaging and an ability to put the number and how to call back if any questions that come up. And then you've got this patient messaging specific care plan, and it's divided into sections. So first is the number section, which is supposed to be the north portion of the compass. And it's addressing those risk factors, and it's saying what the blood pressure was, what the A1C was, and the cholesterol levels. And as you see, I put in abnormal values just to kind of highlight what will come up. But it talks about why is the blood pressure important to me, why is my diabetes important to me after the stroke, and what can I do to help address these things. It supports checking your blood pressure at home using logs, keeping track of blood sugars as well. So all of those things will come up. And this is a generic listing of all of most common risk factors of stroke. And then you've got these are based on previous answers, but the person in the caregiver assessment has reported that they need help with dressing, bathing, getting out of bed. Those are popping up, and it supports how you can get help with this from the community and how the caregiver can be helpful. So you see these are a wealth of knowledge that the patient could be using to help get better. And it's patient-directed. Then you've got generic stroke recovery type websites. And we're also flagging any sort of major concerns that the patient may have. So I'm going to go back because I want to show you this from a different standpoint. So once I previewed it, I'm going to hit continue and finalize the eCare plan. And this is actually a really cool aspect. Let me make sure it came up. Oh man, I think it's because of the training site. But what you'll end up seeing, yeah, it didn't work, is that, okay, go over there, okay. Is that when you build the eCare plan, I'm going to go back to this. What you'll see after previewing the eCare plan and you see the draft report, just click out of that. But what you'll see is when you hit continue, then right here, before you hit finalize eCare plan, there are a list of community resources that the patient has access to that can help address some of the needs that may have been there. So for instance, if there was concerns about financial abilities to pay for medications, or if the patient was having trouble administering medications from cognitive standpoint, and you felt like a blister pack may be beneficial for the patient, then a set of community pharmacies that will actually help perform those types of advanced interventions will be listed here, and it's done by zip code. So that these are resources that are local to the patient's place of living. And you may even see things such as local stroke support groups. You'll also see things like community senior centers with fall risk classes and things like that. These are generally free or reduced cost to the public. And these are lists of things that do not require a medical prescription or order to be performed. And they're up to date with websites and accurate information. If you see a list of 10 of them and you only want 1 or 2, you can select them to not show them on the care plan. So that's how this is generated at the end of the care plan to be able to give to patients to improve their outcomes and fix some of those most complicated problems that are not always fixed with a medication or a prescription or something like that. All right, so I'm going to stop there for a second because I've gone over a lot. I may even take 1 more minute to summarize and mainly focus on how this may impact your day-to-day things as you see patients. So what you'll see is that the phone call is done 2 days after discharge, and he may or may not, it depends on how your site's set up, but may ask for your support in helping to fix any needs that may have come up after the patient was discharged. And then when you get ready to see them in clinic, Dee will go in and perform these assessments and then can come out and verbally talk to you about the highest needs and concerns that were identified. And then after that's done, you are able to go in to see the patient, focus your visit on those concerns that she has said, in addition to all of your general hospital follow-up things that you traditionally do. But now you're powered with an electronic care plan that you give to the patient to summarize the things you talked about. But at the end, it has community resources to help fill in some of those gaps that are hard, that patients could use to benefit to improve their outcome. Does that make sense? So from a day-to-day basis on a charting standpoint, it doesn't necessarily change what you're currently doing. It doesn't have to. We do provide a generic template for hospital follow-up visits that can be used. It's based on the EPIC template, but it can be adapted and you can put it in to use smart text and stuff. You can generate it usually in most electronic databases. So we can provide that to you, but it's certainly not necessary to do. But you know, these are things that are done before. People have already put the work into it. You adapt it to what you need. But Compass does not require you to change any of your current charting that you do for your visit. You do have the option of copying and pasting that provider report, which does give you some good information. So that could be an option there. And the other thing that the one more thing that I will say, I've got 2 more things to say, is that this care plan could be very beneficial to other people who may see the patient. And the most ones we think about could be the home health or the outpatient providers who are seeing the patient, or perhaps the primary care if this Compass follow-up visit is performed in like neurology offices. It's looping back in the primary care with what has happened. So I just want to show you how to share this electronically with others who may see the patient. So I'm not 100% sure if you guys are functioning as the primary care or not. But if you're not, there's this access code here that I copy, and if you go to this website link, you can put in the patient's date of birth, the name, and that access code. and retrieve the plan of care that way. And remember that template I told you that we can provide to you? It has a generic cover letter that just explains what COMPASS is and how, you know, what the patient is experiencing in the model of care. And that cover letter, we actually just paste in at the top of our clinic visit. And so when I get the access code, I will then just copy it and paste it onto that cover letter, so that when I fax my note to the primary care, or if our nurse faxes it to the home health provider, they will see the access code and be able to access the care plan. So after this, we'll certainly provide you with that template so you can see that. And you may need to do a little tweaking of making sure you put your hospital in and stuff like that, and not the other hospitals. But the last thing I wanted to show you, and Megan's going to help me pull this up, is since I couldn't show you on the care plan, I want to show you the database for community resources and those that are specific to your county. And you often won't need to come through it this way, but maybe for a different patient, if you wanted to come look up a resource, you'll see it, you get it through our COMPASS website when you sign on. And you can put in, so what you'll see is a list of host organization names, the program name, phone number, city, zip code, and website. And all of this is printed and given to the patient. And because we have 41 hospitals across the state that are doing the COMPASS model of care, you'll see there's some in Asheville in the west and Wilson towards the east. So you see a ton of that. But what is your local zip code there?
We're 28304.
Okay, let's see if it works. Yeah. So these are in that particular zip code, you'll see the current resources that are there. And these are, and then you have certainly access to this. There's some that are statewide that you'll have access to as well. But I don't know if you've heard of the PACE program or the outpatient rehab, the stroke support group that you guys must have at the rehab center. So that's there. The other thing is you can just put, does that come in? So Fayetteville, you can search it that way. It can always be expanded. So in Winston-Salem, you can see, since we've been doing this now for, I guess, 3 years almost, you'll see our list, which continues to grow. You know what I mean? You can input certain places and frequent resources to help continue to grow that as well.
Yeah, and if there's a resource that you like that you're not seeing come up on your care plans or you don't see on our website, you can always just email us what that resource is and we can update it. So all the patients in that area will get access to it.
Okay.
So that was everything we had. We want to stop and make sure we have the opportunity to answer any questions that you may have.